who may have missed the previous sessions, please don't worry. You can actually get access to all the previous recordings, all the resources that we have shared with you, and the previous speakers that I've shared with you on the iEcho platform. If you have got any queries about how to get access to all these resources, please do not hesitate to reach out to us, and so that we can then guide you so that you can equally benefit from all the resources that are being shared. I'll just hand over the session to Pui for a while so that she can do some housekeeping announcements, and then we'll take it from there.
Thanks, Kajal. So Norman, would you mind starting the slides from the first one? Right, so thank you. So I'll just do a quick few housekeeping announcements. So for those of you who are new here, if you could please change your name in the Zoom box to your name with your area of expertise as well as your country, just so that we can identify who you are. And especially if you're asking questions, it's quite helpful for the Hub members to know where you're from. Please do put your questions in the chat box. We also encourage turning on your video for just better engagement. But if you can't because of bandwidth, then that's all right as well. Please do use the mute button if you're not speaking. And this session is also recorded and will be uploaded. So for any of you who aren't able to stay for the full time or might miss any sessions, as Kajal mentioned, you can access them in the iEcho platform. Thank you. And so we just go next. Just so you know, we can go next again. There are translated captions for this Zoom. So for any of you whose English may not be your first language, you'll be able to have translated captions for that. You just need to find the function down at the Zoom toolbar. Next. So just a quick announcement. So for Malaysian clinicians, we will send you the QR code to fill up the CPD points. For those that are from Japan, Norman, if you can go back one. So for those from Japan, you can submit the certificate of attendance directly to JSAR. And for Australian clinicians, we will be automatically submitting your names to ASHM for the CPD points. Next. This is today's agenda. So starting us off will be Prof. Bruce, who will be speaking about screening and management of cognitive impairment in people living with HIV. Just need to check if Prof. Bruce is back on yet. Oh, he is. Okay, and then that will be followed by a case presentation by Mr. Yifan Feng. So I think that's it for our initial announcements. We've got our fantastic Hub members around here today, and I'll talk to you about the upcoming sessions later on. So over to you, Kajal, to introduce Professor Bruce.
Thank you, Pui. For all the participants and members who are here, I'm sure we have somehow directly or indirectly have had contact with people living with HIV. And we have realized that how the ART has now transformed the care of people living with HIV. They seem to be aging well and almost to a near normal lifespan. And cognitive impairment is likely going to become a more important issue for us to deal with. And we have no one better than Prof. Bruce to be shedding some light on this important issue. Professor Bruce Brew is a professor of medicine of neurology at University of New South Wales and University of Notre Dame. He's also the director of the Peter Duncan Neurosciences Unit, St. Vincent's Centre for Applied Medical Sciences, and also a neurologist at St. Vincent's at Hospital Sydney. He graduated in medicine from the University of Sydney and holds 2 higher degrees doctorates at Medical Sciences from the University of Sydney and a Doctorate of Science from the University of New South Wales. He has a long-standing interest in HIV neuropathogenesis, particularly in relation to cognitive impairment at both clinical and basic science level and HIV-related neurological complications in general. He has designed and participated in numerous clinical studies related to HIV brain diseases and written over 400 papers and 4 books with approximately 35,000 citations. He has served on the editorial board of several journals, including AIDS, HIV, Lancet HIV, and several societies, including International Society for Neurovirology. He has an amazing CV, I must say. Today, he will be speaking to us on screening and management of cognitive impairment in people living with HIV. Prof. Bruce, over to you.
Thank you very much for the introduction. I'll just share my screen, and thank you for the organisers for inviting me to speak. So, I've got some disclosures. They're all fairly straightforward. I don't think there's any real conflict at all. I have given advice to a number of pharmaceutical companies, but it should not be relevant to the talk today. So, by way of overview, I'll talk about some aspects in terms of the controversies, screening, and management, and then I'll try and wrap things up. So what are the controversies, the cause of cognitive impairment? Well, first up, it's a common misconception that hand only occurs in virally suppressed patients. That's not true. People think that maybe it's still all just a legacy effect. Not true. Some people think that hand only occurs when you have CSF escape. That's not true. And another group of clinicians think perhaps it's just a manifestation of getting old, or the effects of comorbidities, or even antiretroviral drugs and their toxicity. That's partly true, but it's not the whole picture. Some people think that hand is overdiagnosed. I'll give you some discussion points to say I think that that's not correct, and that very mild disease does exist, even though some people consider this not to be the case. And then another misconception, but also a controversy, is that people think it's not worthwhile screening for hand because mild disease doesn't really exist and you can't do anything anyway. That's not true. Mild disease does have validity. You can check for adherence and comorbidities, including depression, and get the support for the patient. So, what about then this issue of legacy effect? Now, there is a cohort, or at least there are some clinicians who think that you diagnose brain injury in a patient with HIV, and then you split it in terms of whether it's possibly a direct complication from HIV or it's some sort of other brain injury. And then you can say maybe it's a brain injury related to HIV if they've got suppression, then it's legacy, and then they talk about active disease. And then if it's not virally suppressed, that makes things much easier. That's a nice paradigm, but I don't think it's practical. There's no proven method for distinguishing between direct brain infection and the effects of comorbidities. In fact, the two are often bidirectionally interacting. So I don't think it's practical. Then the second issue is, well, if it's all a legacy effect, how come our group and a number of other groups have shown that, in fact, you can have and develop in the context of viral suppression, and you can actually have progression of hand in the context of viral suppression. It's true that hand may be stable for some time, and it's equally true that a large number of patients will have no impairment. But the very fact that it happens in the context of no significant comorbidities and equally with viral suppression, I think argues against some sort of remote legacy effect from earlier times when the drugs weren't particularly effective. To drive this home again and counter the argument that perhaps hand only occurs when there's CSF viral escape, there's a good paper by Solomon et al. And Lanaka Brewster's group a few years ago now, and you can see even in patients who are suppressed in the CSF, there's evidence of brain viral activity, both RNA and DNA, regardless. This is a small number of patients, but it's been consistently found by certainly Solomon and others, and our group as well. And there's the argument that it's just your patients getting old, as we all would. And I'd like to point out that, in fact, aging is accelerated in HIV. The extent of the quantum of aging is somewhat controversial, but it's of the order of 10 years approximately. There are numerous papers that have shown that aging is accelerated. We've summarized some of the data back in HIV medicine in 2020. Then there's the other aspect of what's happening on the ground, if you like. So this is a study by Jennifer Lamb that I'm sure will come out fairly soon. It was presented only a few months ago. And it's an extension of a study she did some years ago. And the question was, okay, if hand is really around and still occurring, well, we should pick it up in aged care facilities around the country. And this is in the US. So they've done data mining in a number of different centers on both the East and West Coast. And lo and behold, yes, incidence of dementia is higher in patients with HIV infection, as well as the prevalence, as you can see from these two graphs. So something is going on. You can question whether it's all virus or whether it's comorbidities. But the bottom line is these patients, unfortunately, are dementing. And I just emphasize the fact that these were data derived from medical records. So it's not just mild impairment. This is real impactful dementia. Now, what about, the effect of comorbidities? Now, there's no question that a number of comorbidities are accelerated in HIV, most particularly cerebrovascular disease. Again, there's a nice study in Lancet HIV from 2019, and also from Brain and Behavior Immunology some years ago. No question that occurs. Is it a real issue? Is it explaining hand? So the Charter Group in Brain 2023, led by Bob Heaton, showed that the increasing number of comorbidities over a 12-year period correlated with neuropsych impairment. So there's absolutely no question that comorbidities will be associated with hand, but it's not the only explanation. Now these data are a little bit complicated. They are to be presented in the next few weeks at CROI, but the bottom line is we've been studying a cohort now for nigh on 10 years, and we've made sure that comorbidities are quantified as best as possible. And we've also got a long history of the antiretroviral exposure for these patients and antiretroviral suppression at various times over the decade. The bottom line is you can develop, if you like, biotypes in the hand that are independent of the comorbidity burden and their so-called legacy effect. And as you can see, just under half are normal, but 16.5% have incident decline, about 11% progress, and 30% are stable. And this is completely independent of their comorbidity burden and independent of any legacy effect. I'll leave it at that in the interest of time. But the bottom line, I think, is that yes, hand is intermeshed with comorbidities and a legacy effect, but that's not the main driver. And you cannot dismiss hand just on the basis of, well, they were impaired years ago, and this is just a consequence of if you like, brain scarring, to put it loosely. So having said all that, what is the cause then of hand in virus suppressed patients? I would I would think, and I'll present some data to back this up, that what we're really seeing is that there's a likely role for persistent low-level HIV infection affecting the brain, that there are still transcripts being produced, sometimes whole virus, and that microbial translocation from the gut is leading to inflammation, which is revving, if you like, revving things up. There is potentially a role for antiretroviral toxicity, no question with fabrins, possibly with protease inhibitors. So then, what is the relationship to inflammation and neurovirology and neuropathology? There's a good, and this has been a bugbear, if you like, of the area for some years. We haven't had a good pathological underpinning. In the pre-heart era, it was underpinned by degree of encephalitis. In the current era, that's not the case. We do see inflammation, and as you can see, it can vary from just mild lymphocytic inflammation to microbial nodules. Having said that, when you look at the neurovirology, you can see, and this is from Tom Angelevich's paper in Annals of Neurology, that even in the context of viral suppression, you can detect DNA in the frontal white matter, basal ganglia, and in the deeper structures. This is from another group, from Dana Kabuska's group from 2 years ago, and the same message is there, namely that you have evidence of DNA, proviral DNA, as well as RNA. And this correlates with the degree of inflammation and to an extent with the neurocognitive impairment. The drawback with this study is that the neurocognitive impairment was not particularly well characterized, but the message is the same. This is a study that we've built upon from some years ago now when we published it in PNAS. And it's slightly different, but the data that we've built upon is that we have developed an assay that can identify RNA transcripts, in other words, bits of virus that are still being produced, and that correlates. So the higher the transcript number with damage to the frontal white matter that you can detect by MR spectroscopy in the brain. And these are all patients who are completely virally suppressed, that is less than 20 copies. We've taken the data further, expanded the numbers, get the same message, but we've also been able to find evidence of resistance mutations to one or more of their current drugs. And this correlates we've been able to identify this by it's called a long HIV RNA analysis. Again, a fairly novel technique, but you can see that the number of drug resistance mutations does relate to the transcripts, and that correlates with the degree of damage to the frontal white matter. So the higher the number of resistance classes, the greater the damage. This is still in preparation, but I think hopefully will be in print towards the end of the year. Now, how come this happens in the context of viral suppression? The common belief is that you're on antiretroviral drugs, you're virally suppressed, less than 50 copies or less than 20 copies, everything should be fine. Well, it's not, unfortunately, because none of the current antiretroviral drugs work at this critical point in the transcription of the virus. So yes, the drugs can stop viral entry and reverse transcription, but once the virus gets into the host genome, it cannot stop the transcription. Protease inhibitors are excellent in stopping assembly of virus, but you have a real problem with stopping transcription. Now, I mentioned that the gut was important for microbial translocation, and these are data from pathogens 2 years ago now, showing in a monkey model that there was good correlation between viral DNA and RNA in the gut, and then markers of microbial inflammation. and brain inflammation. In fact, the correlation was rather strong and higher than impairment related to viral RNA and DNA in the brain. Now, what about the controversies in terms of whether ANI really exists? Just to remind people, ANI is impairment in neuropsychological testing, but it doesn't lead to a functional deficit. Whereas mild neurocognitive disorder, you have domain testing abnormalities with mild impact, and HAD, of course, is more marked. The issue is it's very difficult to quantify and be precise about how deficits impact on activities of daily living. Now, this has been in some ways addressed by Alan Winston and Serena's article some years ago, but the controversy and the concern is that maybe you're picking up too many patients with, and we're looking at a cut point of 1.5 standard deviations for saying something's abnormal. There is some validity to that. You will, no matter where you put your cut point for neuropsych abnormality, you will always have a false positive rate. 1.5 was used because that's often used in other fields, such as mild cognitive impairment in the dementia field with Alzheimer's, for example. And the idea is that we want to pick up patients early. So we want to focus on mild impairment and try and do something about it, rather than waiting for it to be more significant. And as
Dr.
I said,
Bruce, just
yes.
to let you know that there's 5 more minutes. Thank you.
Thank you. So MCI does have validity and a number of publications, as I mentioned. So I think in this regard, the proposal for Harvey versus Han, I don't think really is an advance to the field. Han does need to be further refined, if you like, but that's a process. Now, what about screening? The risk factors are CD4 count, current and nadir, viral load reading, if it's detectable, a longer duration, previous Han, vascular risk factors, family history of dementia, and substance use, older age. But the vast majority of patients, vascular risk factors in viral and suppressed patients is the most important risk factor. Now, we shouldn't forget that patients are getting older and cognitive decline occurs in the aged patient, in 21% of patients at least. When you're working up a patient, you should also look at their medication burden, particularly in the elderly. There is an online tool looking at anticholinergic burden calculation. That is important because you may misclassify patients as being impaired when in fact it's just the medications. This is just to drive home that there are numerous comorbidities that can affect cognition. Again, a publication from a few years ago. In the interest of time, I won't go through it. How do you approach screening? We need to, I think, have a tiered approach. Identify some sort of risk factor. Then you can use some screening tools, perhaps some MOCA or HIV dementia scale, and then formal assessment. It's important. If you don't ask, they won't necessarily tell you. In more detail, you need a corroborative history. Don't just rely on the patient. And a focused question, such as losing track of the conversation, needing to reread to get things to sink in, keeping lists, hesitant speech, sometimes unsteadiness of gait, difficulty with handwriting and clumsiness and social withdrawal. Some people say, why bother about formal assessment? Impairment in HIV just means HIV impairment. That's not true. As I said, comorbidities can drive things, and it's important to identify those and address them. There are lots of known and unknowns. We don't know the precise extent of how comorbidities interact in the patients who are virologically suppressed. Similarly for vascular comorbidities, they're important. We don't know to what extent they're important. And then there's the issue of if you start heart or ART early, does that mean that you're going to be protected? Probably. Don't know that. More recent data have also focused on the idea that it's the T cell that actually brings in the virus, not the monocyte. because the monocyte can't be infected very well at all. So the T cell brings it in and lights the fire, if you like, in the brain with the microglial and perivascular macrophages. All the data I've shown you so far has really pointed to the fact that there's no true latency. The virus is still active, transcriptionally active, and bits of virus are still being produced, sometimes whole virus. We don't know the extent, however, of whether blood-brain barrier impairment is important in the driving hand. No one has rigorously looked at it. We don't know the extent of gut microbiome translocation. In terms of management, you really have to focus on the history and exam, exclude other causes. Tests are supportive, but definitely not diagnostic. Neuropsych where possible. You can use MMSE and MOCA, but remember they're not sensitive to hand. They're reasonable tools, but they're not time sensitive and they don't assess executive function very well. There's no question that ART improves hand. Most significantly in the ART-naive patients, takes about 3 months, but in the ART-experienced patients, it can take months and months. What about the newer treatments? We don't have data for fostemivir, the long-acting drugs like cabotegravir. We don't have data. Presumably they work. We just don't know the extent to which they get into the brain. 2-drug regimens seem to be okay. We don't know. And single tablet regimens are probably good in terms of reducing polypharmacy or at least pill burden. Neutralizing antibodies, we just don't know. So the principles are treat to viral suppression, screen for comorbidities, screen regularly, I think. How often is hard to know, perhaps once every 6-12 months, particularly in those with risk factors. There needs to be a multidisciplinary approach, minimize drugs, provide support and encouragement, and we need trials to better understand what's going on. The general approach, though, it should be one of treatable traits. And this should be focused on what's relevant to the patient: lifestyle, diet, measures of frailty, focus on relevant comorbidities for the patient. And of course, you can use viral load in a way to assess adherence and as a direct marker of cognitive impairment. We'll move on. This is just very briefly, there are lots of trials that have been done in hand, but just like the Alzheimer's field, they haven't been done well. We haven't really focused on the right patient, nor the right drug. We haven't looked at drug resistance properly in the CSF. We need to make sure that blood-brain barrier is not a confound, and yet it hasn't been rigorously tested. And we need to know what the right readout for efficacy of a particular drug is. In the Alzheimer's field, it's CDR sum of boxes, a pure functional outcome. Whereas we're stuck with neuropsych testing, which is very good to enter, but may not be so good as an outcome measure. A lot of studies have been underpowered and have gone for too short a period. So in conclusion, hand is still common despite suppressive therapy. I think it's related to residual low-level activity of the virus, both in the brain and gut with neuroinflammation. We need better drugs. We can at least focus on comorbidity and management optimization. And there are lots of people I want to thank, but most particularly all the people with, who are living with HIV who have been so generous with the time over the years. Thank you.
Thank you very much, Prof. Bruce, for that very enlightening session. I mean, the entire session, you have brought out so many points, salient points to make us ponder and think and realize that actually there's so much of gaps in our research and so many points have yet really to be answered. But for the interest of our colleagues here who are also seeing patients clinically, I'll just start with a question. Then if there are any questions from the audience, they can feel free to throw the questions in the chat box. From the slides that you showed, some of the changes happens in the basal ganglia region, which usually seems to be a bit more subcortical, a little like what we see clinically in our vascular dementia patients. So I'm just trying to understand Is it because of the neuroinflammation that's going on? Do you think our patients with HIV present a little bit like how the vascular dementia presents? Because clinically, what we see is actually psychomotor slowing, troubles in their executive functioning, problems in their focus, which is very different from what we see in Alzheimer's. Essentially, would always be memory, amnesia, and all that. So maybe these are some points where we see patients clinically. We can start picking and looking at these subtle points.
Yes, that's very true. The overlap in clinical presentation and even neuropsychological presentation between patients with vascular cognitive impairment and HIV-related cognitive impairment is profound. In fact, phenotypically, there's not a whole lot of difference. Yes. The burden, of course, with vascular cognitive impairment is in the frontal white matter, and that's also the chief, in virally expressed patients, that's the chief area that's still involved. Basal ganglia are involved, but not as much as frontal white matter. So it makes sense that neuropathologically and to an extent virologically with low level production, that the same anatomical area is affected.
Okay, thank you. We do have question, maybe Jenny, you want to?
Thanks. Hi, Bruce.
Hi, Jenny.
So you talked about the importance of inflammation with neurocognitive impairment. And given that we don't have any transcription inhibitors and people are virally suppressed, have there been any studies or is there any indication for anti-inflammatory agents to help HAD?
Right. So in the current era, there are no studies that I'm aware of. Years gone by, there were some anti-inflammatory studies, very small, and they were not encouraging, certainly weren't positive. That doesn't mean that you shouldn't do it, most particularly now that we've got such better drugs and hopefully the degree of inflammation will be less. So maybe the same strategy would work in the context, hopefully, of less inflammation. If that's true, what would you use? That's the problem. Statins, as you know, do have an anti-inflammatory component to their efficacy. So there is some logic to using statins and being liberal with their use. With the REPRIEVE study, you're probably going to do that anyway. But beyond statins, it's not clear at the moment.
Oh, can I just a follow-up? Bruce, are you aware whether there was neurocognitive assessments in REPRIEVE? Are we going to get some data from REPRIEVE on this?
To my knowledge, there weren't. Great opportunity lost.
There's a question on the chat box. Basically, is the gut microbiome in HAN different from the other types of dementia, for example, in Alzheimer's?
Great question. I don't think there's enough data to confidently say there's an Alzheimer-friendly gut microbiome, or an Alzheimer-unfriendly, if you like, and a HIV-unfriendly and unfriendly gut microbiome. Don't think there are enough data. The common theme with the gut microbiome is, at least at this stage, is that it's not a particular microbe. It's really what the population species might produce. It seems like butyrate might be one of the common links, but I am hesitant to be very dogmatic at all. Butyrate is anti-inflammatory. That's the reason why that may be the common link.
Okay. So I guess there's still a huge gap in research to answer all these questions, and actually more opportunities for us to try to dwell into all this and get some answers. Thank you very much, Prof. Bruce. As per our usual pattern of how we do these sessions, we actually will be having a case presentation. Prof. Bruce, we would love to have you staying around so that then you can also help shed some light for the case presentation. But I'll now like to invite Yi Fan. Let me just introduce Yi Fan first for the case presentation. Yi Fan is a dedicated HIV advocate, currently serving as the Deputy Chief Executive of Harmony Home Taiwan. With a strong political science and social services background, he has been actively engaged in HIV-related advocacy, non-profit leadership, and policy development for around a decade. Yi Fan holds a Master's of Social Sciences from the Graduate Institute of Latin American Studies at Tamkang University and a Bachelor of Arts in Political Science from National Chung Cheng University. Since 2015, Yi Fan has been an integral part of Harmony Home Foundation in Taiwan, progressively taking on leadership roles such as Executive Secretary, Office Director, and now Deputy Chief Executive. Beyond his role at the Harmony Home, Yi Fan has played a key part in the Taiwan HIV story, serving as a chairperson since 2023 and previously as Executive Director from 2019. Recognized for his amazing leadership and commitment, Yi Fan is also a Taiwanese Fulbright visiting scholar to the US in 2024 academic year. His ongoing work continues to shape Taiwan's HIV response, bridging policy, community action, and healthcare innovation to create a more equitable and inclusive society for all. So with great pleasure, we'd like to invite Yi Fan to share a case study so that we can try to have a better understanding how we clinicians face patients on a regular basis. Over to you, Yi Fan.
Hi, let me share my slides. Okay. Okay. Hello, everyone. I'm Ivan Fan. I'm the Deputy Chief Executive from Harmony Home Taiwan. And our organization major focus on those provide shelters for those people living with HIV. And we also help them access to healthcare services. And today we would like to present our clients. Oops. And here is my outline. I will go on the overview first. Then we have some case summaries and social factors and medical history. Then we will have the discussion. And I want to highlight the discussion points first. The first one we want to discuss is that we want to establish the strategies for addressing the patient's multiple medical needs, including pressure ocular care, improving nutritional status, and implementing swallow rehabilitation plans. And the second is we want to establish a process for like referral and resource connection when our clients' needs become more complex. Now, let me introduce today's case. We call him Sweet Potato. He's a 41-year-old man. And we found that, as we know, he identified himself as gay. And he's also a very common Asian Taiwanese. And we found that he's one of men who have sex with men, the key population. And also he has some issues with crystal eyes and chemsex. And now about the prison complaint. Sweet Potato became our patient in November 2024 and began his rehabilitation therapy sessions. And now he's totally paralyzed and also with bedridden status. So he's very difficult to express himself. And we also found him that he have a pressure injury in sacral area. And we have to use the high back wheelchair and also with reinforced. And he will need people to help him to transfer to one place, from the bed to the wheelchair. About the nutrition, because he cannot move and swallow, his swallow function is very not okay. So he's on tube feeding with liquid diet, and his diet is including 20% of higher percent. And about the vision and hearing, he is nearsighted. He have to use the glasses so that he can watch TV or program. But we didn't find any significant hearing problems. And he can only communicate with his family or our service providers through blinking or eye movements. And he can use very limited, minimal vocal or voices, and also use a little bit lip movements. About his cognition and sleeping problem, we found that he have intact cognitive function. He is unable to distinguish time, place, object, and people according to the doctor. Now he have to use some medication before sleep. And as the mental health issues, we didn't find any further records about his psychological or psychiatric disorder. But we found that he have mentioned about some of his depressions or anxieties to previous case managers. We found that in previous records. And about the ADL, he have 0 point of ADL. And also IADL is 7 points and BADL is 6 points. And about his physical activity, the patient have only can have partial control of neck movements. And he have a very habitant of leftwards tilt of the neck. And his swallowing and speech function are also affected because of his paralysis status. And about the social factors, the patient's parents has domestic violence issues. So his parents divorced many years ago. Sweet Potato stay with his mother, live with also with his older sister's families, including his sister's husband and children. And Sweet Potato have some friends, majorly primary work his former colleagues. And we didn't know much about his social relationships because he cannot express himself. We can only learn about his relationship issues from the hospital's records. And his family is informed about his HIV status from the hospital, and also about his substance use issue. And about his sexual history, we didn't know much about that because we can only find that he identified himself as gay man according to previous reports. And his family also learned his sexual orientation from the case manager. Yeah. And about the substance use history, we have found that he have issue of crystal eyes, and also he have frequently use alcohol, but we didn't know about the frequency that he used alcohol or crystal eyes, so it's unknown. About the housing before the stroke, the patient lived in the rental residence in New Taipei City with his family. And now about his occupation, he used to work in the theater industry but he became unemployed 2 years ago. And since then, Sweet Potato only have some freelance works like filming or video editing. And about other social factors, we know that he would like to listen music or singing, even he cannot express him very well. And also he would like to watch sport games on TV programs, and he would like to admire women. And also he wants someone, maybe his friends or families or our service providers, to tell stories. And Sweet Potato have a very good, well, we think good support and care from his family and friends, because we felt that his family and friends were willing to pay for better medication and care services. And his family member visits him, come to our shelter very often. Also, his older sister will accompany him to go to the hospital to go on the rehabilitation therapy. And his former colleagues and friends also come to our shelter two times every week to chat and also help him with the bedside rehabilitation. And Sweet Potato have faced some challenges in seeking long-term care facilities because in our in Hamilton Home, we are only the house or shelter. We are not a long-term care facility. So he has the need to seeking for a long-term care facility, but it is very difficult for him, for his family, and our service providers to help him to find a very near place for him. And in coming home, his family felt that he's more peaceful because it is. He felt that our shelter is more friendly to people living with HIV and LGBTQ community, and he only receive around 200 US dollars allowance every month. Occupational and speech therapy at Hospital D, and including self-funded transcranial stimulation therapy. And on the same day, he have completed the second session of physical and occupational therapy on Hospital D. And about the vaccination, he has influenza vaccination in November, and also received 3 dose COVID vaccination, but not vaccinated for Mpox and HPV. And as he didn't have any side of infection of HCV, and also his CD4 counts in September, his CD4 is 248, and the viral load is 25,339. But in November, his CD4 is 448, and his viral load is undetectable. And in his recent and other investigation is on November 19th last year for medication refill and do some blood lab test. and also have some assessment by the rehabilitation department for therapy plans. And he's now on TrialMech, which is ABC plus 3DC and DTG. But we found that sweet potato is diagnosed in 2021, but he's not going back to the hospital frequently. And here is his current medication and his doses. He have TrialMech, we have mentioned before, and he also have Ducolex, which is bisocolidisop. He have 2 doses before sleep and 3 times weekly. And he also extazosine and polymesol, 1 pill for 3 times daily, and also Zopiclone, which is 1 pill before sleep, and Senosides A plus B, 2 pills before sleep, and Crantiopine, half pile before sleep. And so we will come back to the discussion. We want to know about how to build or improve our strategies for addressing sweet potatoes' multiple medical needs, including his pressure ocular care, also improving his nutrition status, and to help with like swallowing rehabilitation plans. And also we worry about maybe sweet potatoes needs will become more complex. So we would like to establish the process for referral or to connect some resources for him. Yeah.
Thank you very much, Shifan. Indeed, a very complex case, I must say. Maybe we'll just open the floor to some questions. If anybody wants to clear some doubts, they want to ask you for the questions, clarifications with regards to Mr. Sweet Potato. Any questions that you all want to clarify, ask Yifan further?
Yes, do we know the cause of the stroke?
Good
Yes.
question. Yeah. Do we know the cause of the stroke?
The physician said that it might be because of his age, because he didn't come back to the doctor very frequently. So he has relatively very low CD4. So, but we didn't know much very about the stroke. Yeah.
I think it'd be important to try and clarify that, because HIV itself would be an unlikely cause for a stroke. It can happen. You can have HIV vascular disease, but it's unusual. And whether he had endocarditis, for example, from his drug use, or some other cause. I guess the other issue, obviously, is we have to think about changing the TrialMech, getting the Lenacapavir out of the equation, given he has had a stroke. Presumably he has some degree of vascular disease.
Yeah, and also because sweet potato is, well, he have a history of substance use and cancer. So maybe it is also some because of the substance use. Maybe we don't know. Yeah.
Any other questions to clarify with regard?
It's Jenny here. Can I get a sense of whether, since he's been in rehabilitation, whether there has been any improvement? Has he, I understand he was bedridden with virtually no movement of arms and legs and just eye blinking as a communication. has he gained any movement? Because we're talking, this happened in June 2024, which is quite a while ago.
Yes, it happened in June, and he come to our shelter in November. So there's so many months between, and he transferred between 3 hospitals. And he's now still on therapies, and we found that he have very little improvement now. Yeah, we can hardly say that it's been improved, you know. Yeah. Yeah, but we are still trying to and hoping that maybe his function will recover in the future. But so far, we are very little or hardly say that he have recovered or to regain some function. Yeah.
Okay. Yifan, there's some questions. Basically, is sweet potato improving? I think you rightly said earlier that you haven't quite seen much improvement. When do we consider withdrawing treatment? So Jaslan, maybe we will just keep this question for the end a little, because I definitely think you brought up a very good point for us to start discussing advanced directives given his current condition. But you have another question, Yifan. Can he feel pain, like the pressure ulcer pain, because he has got a
Yeah, he has. Well, the injury is smaller now, so it's recovering. So that's I think it's one of the significant success of sweet potatoes. Yeah, and it's getting smaller, and we think in the future it will eventually recovered. Yeah.
Okay. Kenneth, you have got something you wanted to ask as well?
Yeah. Thank you for your presentation. So may I clarify with with you that the age of this guy, sweet potato, is 41, I believe.
41 years old.
Okay. So thank you for sharing, and so sad to hear that such a young man got already bed bound at this stage. So because I'm a physio in Hong Kong, so I'm interested in the rehab plan for sweet potato, and knowing that he can only control a part of neck, right? So he can only move the head or moving the eyes, and it's a very I think will be largely limited the functional mobility. So I think for at this stage, sweet potatoes should have a lot of the passive movement, or at least maintaining the joint range and preventing the contracture, right? And I think he leads a lot of the nursing care. Perhaps some nursing colleagues can share with us about the nursing care plan. And also, for me, I'd like to think, can he actually sit up or stand up? For example, even for some bed-bound patient in Hong Kong, we will also try to get him up. Perhaps it's just a passive sitting or a supported standing, but having a stand up posture will be better for the psychological status. And but of course, we also need to care about the sacral shore, because the sacral shore will also limit the time for sitting. And in the care in the community, we will also suggest that perhaps we can bring him out. For example, transfer out to a wheelchair and then try to do some outdoor activity together with the family member. And also nowadays, some of the motor neuron disease patients in Hong Kong, we try to arrange a computer in front of the patient's bed, and also we can use some technologies, just like some eye tracking device. Even the patients cannot move the hand, the eye tracking device can actually sense the movement, and so that the patients can actually type some words in the computer, and the computers will help the patients to do some communications. That will be might be helpful to help the patients to connect to the outside world, even though the patients cannot move. And yeah, but I think at this stage, I noticed that the physical progress will be quite slow, or somehow this is not reversible. But at least we can try to do something to help the patients to connect to the art to the outer world. Yeah.
Yeah. Thanks, Candice. In our shelter, we will have our care providers, and also sometimes sweet potatoes families or friends will come, and we will help him to sit up passively. And also we will help sweet potato scratch like his arms, his hands, or legs, and so on. And during this process, we felt that sweet potato will be happy, because he don't need to stay on the bed for 24 hours every day. And as if sweet potato have so many chances to go out, we will have some activities if his families or sweet potato express. Mostly his families wanted if like us to take him to go out. And for example, sweet potato have go back home during the Lunar New Year for 2 nights to stay with his family. Then he come back to our shelters for to go on his therapy and services. But due to his very limited function of mobility, we can only use the wheelchair to take him out. But I think sweet potato love to go out, and we are trying to take him out more to try if sweet potato will have more chances to getting better. Yeah.
Yeah. I agree with you that by more increasing the outdoor activity, that the sweet potato should be more happy. Just beware about the sacral shore, because the sacral shore will limit the time of sitting. So if we go out with the wheelchair, so just make sure that the wheelchair got a very good cushioning.
Yeah. Thanks. Yeah.
Thank you, Kenneth. Yifan, I just wanted to bring to everyone's attention, his symptoms started in June. Basically, he was diagnosed with stroke in June. And you mentioned that the first session of physiotherapy started in December, on December 3rd, right?
It's November. Sorry, the first session is in November. It's
Okay.
yeah.
So November 3rd. So basically from June to November, and the first session was in November 3rd. So maybe if I can just pose a question to Prof. Julia, who is also our rehab physician, on what is the best window period where intensive physiotherapy should kick in to be able to get the best outcomes? And number two, really, how do we set for, like the rehabilitation goals for patients, especially like this, who really need much of nursing care? And how do you decide from there?
Right. Okay, thanks, Kejal. Right. So, if you look into brainstem stroke, right? In general, right? So, and any stroke, we would really go intensive within the first 6 months, but we know improvement can occur up to a year, right? And for Mr. Sweet Potato, I see they have multiple rounds of rehab, and also I assume that when you have PTOT and speech, swallowing has been tested and it's confirmed that there is an issue. So NG tube was inserted. So so at this point of time, let's say this patient comes to me, right? So it's really, that the physical progress is slow. So what would I do? Right. First of all is, of course, looking into prevention of further complication that can make it worse. For example, like Kenneth said, contracture, nursing care, turning, and as much as possible, sit down, and if there's a tit table, to stand it up has tolerated. So to prevent further problem, right? Pressure injury or contracture, they can make nursing care a bit difficult. Number two is looking into
what else can I do to improve his independence? This one, from the sound of it, it looks like a lock-in syndrome. So only using your eyes, you can't even verbalize, right? Can he make any sound with his mouth?
Yeah, but very limited sound. Yeah, you
You're
can
right.
use just voice, very like or
All right.
Yeah.
Okay. So the next one I would look into is how can we help him communicate with other people? Because I think it is very frustrating for them trying to, let's say my head is itchy or what, but you can't communicate it. And then people be guessing here, guessing what you want to say. So I would like to establish a more effective way of communicating, and it can be simple like the alphabet board, or you have to work with him what are his common needs, right? Whether he's hungry, whether it's painful here and there. So establish a way of communication, because that can relieve a lot of frustration. So that is into communicating. Number 3 is, like Kenneth said, is connecting with the internet, because otherwise you feel so lonely. And with internet, you can go to social media. So there are many gadgets now available. Just using your eyes, or maybe he can't, but there's also a gadget where you click with your mouth. The mouse is in your mouth, so you can click it accordingly. So the next one is using your eyes. So try to find those gadgets to help him connect with the outside world. Number 4 is mobility, right? So he has a wheelchair. Make sure there's a good cushion. Of course, people can push him, but well, there are what to say, advanced wheelchair. Not to say that it's accessible, but advanced wheelchair where you control with your muscle of the head, where you can control right, left, and so on. It's not that easy. We have one in our unit, but it's not easy to learn. But there is a possibility. The next one is controlling with your chin control, like this, where you can control a wheelchair. And the next one is, of course, the one that our Superman used, which is sit and puff if he can, right? So this type of mobility give me a bit more independence, and I can hear that he would appreciate that, right? So these are the things that I would explore if, let's say, I have this patient referred to me. So the prevent further complication, communication, internet, and also if you can increase the mobility, because they will feel much better, be able to move the wheelchair on their own, right? And thank you.
Thank you, Julia. Yeah,
Thank you, Julia.
yeah. I think the suggestion is very helpful, because maybe we didn't think of that we can use this kind of gadgets or tools to help sweet potatoes to improve his independence, and also his well-being and happiness. And so I think we can do is to trying to connect with these resources in Taiwan, maybe. So if our social workers or our case managers can find these resources, then we will very happy to help sweet potato, yeah, to have it. Yeah.
Definitely. And while we are discussing this very interesting case, if any members of the audience or even our hub members, if you know of resources that will be helpful to our participants or even, our patients and our clients that we are meeting, even if it's only specific to your region, please do share it across, because then we'll be able to share with all the other people as well. Just going back to rehabilitation, Prof. Julia, what do you think about this following? He has been on NG for almost 5-6 months now.
Right. So I would like to know what is the solving problem. I mean, normally when we have this, we will see, is it really can't solve at all? or can we modify the diet? Diet, there's a lot of diet modification we can do if he's able to solve. So that aspect I'm not sure. So let's say has sweet potato did things like assessing the swallowing assessment with the scope, or trying to do the swallowing assessment using the x-rays to see what's the problem with swallowing. So not too sure whether that has been done. Let's say it has been done, and I think we had to make clinical judgment, should we reassess again or not? So normally stroke patient, we might reassess again the swallowing ability, depending on what you find during the assessment. Yeah.
Yeah, and I want to add something, because sweet potato now can eat very small particles, very small, but we hope that he can improve. And because the fruit in tube is not good.
Right. Okay.
Yeah.
So maybe it's time for him to have a reassessment, because sometimes they do improve, right? And
Yeah.
of course, even if sweet potato can eat, the next question is it enough? So
Yeah.
sometimes we allow them to eat, but you have to be supplemented by the tube as well, because otherwise they're not getting enough nutrition.
Yeah. Thank you.
So given that the amount of nursing needs that that sweet potato would need, maybe I can now turn around and ask Sister Chen Hong to tell us that how would you advise the caregivers and even family members to, to improve the nursing care for this patient for a better quality of care for the patient?
Thank you so much, Kajal. So I think this is indeed a very challenging patient, and the amount of nursing care that the patient needed is really great. So I think managing pressure ulcer is one of the questions being brought up for discussion. I would just say it is multifactorial. So first, we have to ensure good wound care. And the wound care and the wound product that we use for pressure ulcer is not like fixed. It's quite dynamic. So a nurse consult and also recommendations for proper wound product is very important. And then after that will be pressure relief. Pressure relief can by a few measures. I think the most common will be air mattress, and then a regular turning, usually is 2 to 3 hourly. With good nutritional support, especially adequate protein intake. So this is when that we say, even though patient probably can swallow a little bit, but it is more like for pressure feeding rather than meet the adequate nutrition needs for this patient. And also other areas like incontinence care has to be addressed. Not sure if this patient have any issue with chronic diarrhea or any urinary incontinence or any long-term indwelling catheter. So this will involve another a set of care that usually we provide for long-term bedridden patients. So I think for just now, Candace mentioned about the augmentative and the alternative communication tool, which usually not necessarily have to be a high-tech device. So like the air tracking device, which is readily available. I think one of the common equipment we use in Singapore is called Toby. I have no conflict of interest in this, but I just mentioned a few products that we are using. So Toby is an air tracking device. Other than that, we can use a low-tech letter chart. I feel because this is important, because that we need to establish patient's mood. In patient who like sweet potato, he will probably quite depressed from time to time, and assess for pain. Another symptom is also very critical because the limitation of communication. So, and also because he's 41 years old, but with considerable amount of disability. So I think establish the goal of care is also important, which at least we have to understand his care preference. So with good communication tool, or at least we can understand some needs on this aspect. Yeah, so I think Prof. Bruce has his hand raised.
Yes. Does he have feeling in his arms and legs? Can he blink his eyes in relation to pain? Or
有一点. Well, a little bit sense, yeah,
okay.
yeah, a little bit
Yeah.
sense, yeah.
So I do agree that it's really important to have him reassessed. It doesn't. It
Yeah.
really doesn't feel like a brainstem stroke.
Well,
And it could be,
yeah.
but very odd. You know, HIV disease patients can also have motor neuron disease. And sometimes about 50% of them will respond to antiviral therapy, but it can take a while.
Yeah, according to the doctor, their assessment, he think that sweet potato have conscious and he can know what's going on outside around him. So I don't know whether it is he has sense, but maybe he know that we are beside him or around him. So he will interact with his family, friends, or also our care providers. Yeah.
Sure, but if he's got motor neuron disease, you know, there's still a few months for him to potentially improve with antiviral therapy. But then if he is one of the patients who don't, he'll just continue to get worse.
Jenny, you have your hands up.
I just wanted to make a couple of comments from a clinician's point of view. As Bruce mentioned earlier, when people have a stroke, if it's a stroke rather than a hemorrhage, we would consider getting that patient off the abacavir because of its cardiovascular risk. But I wanted to direct everybody to the EACTS guidelines where they have which antiretroviral medications are safe to crush to put down a nasogastric tube. So at the moment, he's actually on a medication, abacavir, lamivudine, and dolutegravir, which you can crush, and you will get good levels of drugs. But if you switched him to Biktarvy, that cannot be crushed and put down a nasogastric tube. So it would be really important to have a look at those guidelines or recommendations if you are considering switching therapy and getting him off the abacavir. There are many combination pills that cannot be crushed to go down a nasogastric tube. And I'm assuming that that's the way he's getting his antivirals at the moment, given that he's now got undetectable viral load. I wouldn't switch him to dolutegravir lamivudine because he's only recently achieved that undetectable viral load. He's had periods of poor adherence. He may have mutations in the background. So I would be very careful about that. The other thing thank you, Rena. The other thing that I was a little concerned about in the patient's history was the disclosure of his HIV diagnosis to his family. And I'm presuming that was without his consent. And in Australia, that's illegal. You cannot do that. And I don't know whether the same laws apply in Hong Kong, KL, etc., Bangkok. But certainly you could not do that in Australia.
Thank you. Yeah, well, I think his ART is being noticed that because his sweet potato is tube feeding. So I think the case manager and the doctor have been considered about the crushing pills. And about the consent of his status, well, as we know, when he's transferred to Hong Kong, then everything is happened. So, well, it's too late for us to help Sweet Potato to protect his privacy. But fortunately, his family is still wanting to support Sweet Potato. So I think he's very lucky. And I think it is a very good point that we have to reconsider if we have a client in Taiwan in a similar situation and how we can help the clients to protect the privacy and also help his families to have access to some services so that they don't have these kind of heavy burdens to taking care of his family. Yeah.
I agree. He's very lucky. He seems to have a very supportive and loving family. It doesn't always happen that way, though.
It's
Yeah.
not very common in Taiwan, you know. Yeah. Yeah. Thank you. Thank you.
Yifan, I also think it's important at this point. I know we are just going to be close with our time, but given how complex he is and you know how his prognosis will likely be as time passes, whether it's MND, whether it's just a brainstem stroke with a lock-in syndrome, because he's probably just using his eyes and barely making any sounds. Maybe it's also time to talk about the goals and directions of care. So maybe if I can ask our geriatrician, Dr. Virasa, what do you think of how do we start talking about advanced directives for patients like this? I mean, he is young, no doubt, but he definitely has got quite a debilitating condition. He's been completely bedridden for the last 6 months, and overall prognosis will definitely be guarded. And he would likely be at risk of more complications coming in. He's already had a pressure injury. So maybe Dr. Virasak, if you can just shed some light on advanced care planning.
Yeah, I think this case we should start about talking about advanced care planning because his stroke it was more than 6 months ago, so he's very low chance of more recovery than this, and now he has a complication of immobility. And he's in the status of bedridden. So I think probably we can talk about to his family and to himself because he still can communicate with us with blinking an eye movement. So I think in terms of if he has emergency condition needing to the life support, so do he and his family still need for the further invasive treatments? But we still have the best supportive care for him and his family. Yeah. And maybe we should start thinking about the prescribing in medication, which is unnecessary. I'm not sure about the whole medication that he's got at the moment, because at the end of in the palliative settings with bed bound, sometimes we need to deprescribe or stop some of medication, which is unnecessary.
Yeah, definitely. And I think Jazlan had a question. If Dr. Virasap, you want to take the question on when do you start withdrawing treatment?
I think we now we can see the list which medication which is less likely to cause benefit more than so we can start withdraw the treatment at the moment, but some medication which still give the benefit to somehow we still prescribe give the medication to him.
Okay, so basically we can always start deprescribing and also at the same time reduce the acetylcholine burden like Prof. Bruce had mentioned, because he was also on an antipsychotic in the list of drugs which he probably doesn't need because he is really totally bedridden. But for all of you who are still tuned till now, we actually have got a session coming up on advanced care plans, so stay tuned. In the interest of time, I would like to wrap the session. Thank you very much, Prof. Bruce, and also Yifan for such an interesting session. I hope you all will stay tuned for the upcoming sessions and find these sessions beneficial for our clinical as we serve our patients. I'll hand it over to Pui Lee for any final comments and announcements.
Thanks, Kajal. I think today's session has been so wonderful and the discussions have been very fruitful. So thank you to everyone. Just to not keep all of you, I just have a couple of announcements. The first is please don't hesitate to join us for the upcoming session on polypharmacy and e-prescribing. So that would be in March. And in April, we'll be talking about management of pain. So we'll be having our speakers as well as our hub members talking through cases as well for these two sessions. So please do join us for those. And one more announcement is that please do fill in the feedback forms. We do take note of them and it helps us to improve on our sessions. But the feedback form for this session may be a little bit longer because it's the midpoint of our program and we really want to see how we can make things better. So please do, fill in these forms. So I think that's about it. And if any of you are keen to present a case for our upcoming sessions, please email us as well. We're always looking for case presenters. And we thank you so much, Yifan, for bringing this case today. Okay. Thank you very much.
Thank you, everyone. Have a good
Thank
evening.
you.
Bye-bye.
Thank you. Bye-bye.
Bye.
Bye. Thanks.